My second winner for this talk is atrial fibrillation. Atrial fibrillation is type of irregular heartbeat. Some of you may have heard about it, some other did not. And I will explain to you in a second what type of this irregular heartbeat is that. But why it's important? Because similar to hypertension, this is the most common arrhythmia in the world. And in the United States by itself, there are more than 10 million people with atrial fibrillation. When we are in the 40s, we're not much worried about it. We don't see much of it. But if you look on this slide, it's almost zero here in 40. But look how it jumped. By the time we reach our 70s, 1 out of 4, they have atrial fibrillation. And it's not much different from hypertension. A lot of patients, they don't feel it. Some patients are more sensitive compared to others. Every time they have a regular heartbeat, they may feel it. Other people, they may go years and not knowing about atrial fibrillation. Now, probably with having smart devices, maybe some people recognize it more. What are the risk factors for it? It's not much different from hypertension. There are a lot of overlap. Definitely, aging is one of the risk factors. All of us, we move in one direction. We don't get younger. And older we get, we have higher risk of having this problem, the atrial fibrillation. Other risk factor increase it, body size, obesity. Actually, one interesting example I learned from one of my doctor when I was in training. You have elephant and mice. The mice never get atrial fibrillation. Elephant, they always have atrial fibrillation. So for some reason, it's related to the body size. So bigger we are, higher risk we may have atrial fibrillation. Diabetes, hypertension, sleep apnea, obesity we talked about, lifestyle and activity, smoking, also big things, and sleep apnea, another big things. It could contribute to that. Some patients are asymptomatic, but this disorder may have a little bit more symptoms than hypertension. Symptoms, people may feel shortness of breath, they may feel tired, they cannot carry a lot of exercise and activity. They may have palpitation, feeling their heart racing fast. If the heart is racing too fast, sometimes it gives them chest pain. So the atrial fibrillation, this irregular heartbeat, the normal heart, you have like beat here, start, it go transmit, and the all heart work in synchrony. In atrial fibrillation, you have the top chambers of the heart. Each part of it, it giving this weird signal all together. So the top chamber of the heart is quivering, is not doing the job it should do, and is not transmitting the right message for the bottom part of the heart. So the bottom part of the heart said, okay, well, that's so confusing. I'm not gonna follow this. So this is go in by itself in different rate, and this go in different rate, and sometimes both of them, they go so fast. Why this is important? Because when you have this kind of a problem, there is a piece of this heart, we call it appendage, because it's not beating good, the blood becomes stagnant and it may form a clot. If this clot break loose, may go to the brain and cause a stroke. Also, if the heart is beating too fast for too long, it gets weaker. It cannot keep forever beating fast that long. And people, they have heart failure symptom. So, not similar to blood pressure, not all people the same. If they have atrial fibrillation, more risk factor you have, higher risk of having complication with this type of rhythm. If you have high blood pressure, if you have previous stroke, if you have previous MI, blockage in the arteries in your heart and your legs, all of that add on. And this score, as the numbers goes up, the risk goes up. Now, if we give them on blood thinner, the risk of a stroke go way down. Doesn't go back to zero, but it decreased more than half. If you look into this, despite people knowing they have atrial fibrillation, good number of them prescribe medication, the best compliance is not more than 60%. So even we know it's serious a problem, not all people with atrial fibrillation, they are on the right treatment. When we decide if we're gonna put people on blood thinner, there are different scores we calculate to know what is your risk of a stroke, what is your risk of a bleeding, and we weigh these options. If we feel the risk of a stroke higher than the risk of a bleeding, we put patient on a blood thinner after we give them the proper education. But if we feel the risk of a bleeding is low and we put them on a blood thinner, it's not always 100% guarantee that you will not have a problem with it, but we could estimate that your probability of having problem is quite low, and you probably will benefit of taking this, protecting you from a stroke, which is very debilitating issue. But some patients, when they started after a while, after 5 years, 10 years, whatever number of years, they may have a problem. They may are on a new medication, they may interact with it. It may become too much for them to take all these medications, so they drop this blood thinner. Some of them spontaneously bleeding if they have issue with their bowel, their stomach. Some of them, they don't become like steady on their feet, they have falls. All of that increase their risk of a bleeding or if they are on a blood thinner. Is there anything we could do about that? So the same concept, they went back. Let's see, what is the problem? We say atrial fibrillation causes stroke. Why it causes stroke? Because this part of the heart, this people form a clot here. And when this clot break loose, it go to the brain, causes stroke. So they thought, okay, why don't we get rid of this all over and just eliminate this risk? And they start doing this first with surgery. When they do open heart surgery, it's a piece of the heart. We don't know what is the function of it. There is no proof like it's beneficial. They just cut it off and eliminate the risk of stroke. And with years, people got smarter about it. Say like, if we close it and get rid of it with surgery, can we do it with minimally invasive way through catheter without opening the chest all the way? We came with these devices, and this device, it's small plug through catheter. We go through the vein and we go to this area. When we deploy it, it doesn't have circuit or anything. As you see, it looks like a strawberry. It closes this area and seal it off. So clot don't come out and cause a stroke. This is different type of device. The same way of doing this procedure is just different device. Both of them, they have been approved since 2016. So they are not experimental devices. The people who have any problem or risk of having problem with the blood thinner could be candidate for this. It's outpatient procedure. It takes about 30 to 45 minutes. Most of the patients, they go home on the same day. Is it safe? It's extremely safe. The risk of any major complication is less than 1%. Is it successful? The success rate is close to 99%, and ultimately 96% of patients who receive this procedure, after 6 months, they stop the blood thinner and they take only baby aspirin. This procedure does the job of the blood thinner. It decreases the risk of a stroke by half. But the difference, you have it once and you are done with it for the rest of your life. This is one of the procedures I have done. So we go with the catheter. We identify the area where we're gonna put this device. We give some contrast. We confirm we are in the right place. Then, as you see here, we put the device and we close it off. We pull the catheter, patient go to the recovery, and in a couple hours, hopefully go home.